My name is Manahil and I'm an undergraduate student at the University of Maryland. It is a great honor for me to introduce Dr. Rosenblatt. Dr. Rosenblatt is a medical oncologist affiliated with the University of Maryland Medical Center and has been practicing for over 10 years. She is certified in internal medicine, hematology, and oncology by the American Board of Internal Medicine. She is also an assistant professor at the University of Maryland School of Medicine and is a published research author. I would now like to request Dr. Rosenblatt to start today's session. Thank you.
Hi, everyone. Thank you for the lovely introduction. So my name is Paula Rosenblatt, and I am assistant professor at the University of Maryland. I'm a graduate from College Park, and I'm really excited to be here and talk with you all today. So we're going to be, I'm a medical oncologist, and I'm going to be sharing kind of what my typical day and what a patient goes through. Minahil, oh wait, never mind. I have the access here. There we go. All right, can everyone give me thumbs up if you can see my screen? Excellent. And you're hearing me okay? Thumbs up. Audio is working, excellent. So today I'm going to kind of talk a little bit about how I came to be an academic medical oncologist, and then just give a little kind of Cancer 101 discussion of the epidemiology, and then go through what a breast cancer patient goes through, and then have some open questions. So being an academic medical oncologist. So how did I get here? So now I realize it was almost 20 years ago that I was where most of you guys are in undergraduate, thinking about going to medical school. So to prepare to go to medical school, I worked in one of the biology labs. And I dissected little Drosophila, tried to pull out their salivary glands. I don't think I was very successful at it. I'm pretty sure I worked for an entire year doing Western blots and realized only at the end of the year that nobody had the instructions that it had to incubate at some period of time for 2 hours. So I worked for a year. I got no results of that, positive results. But I did learn about what research entails, and it was a fun experience working with everybody in that lab, and it continued to get me interested in science and that kind of pathway forward. I did graduate from the with a degree from the science department, neurobiology and physiology, and I picked that because to me it sounded like a double major. But I really do encourage people. I do a lot of talking to medical students and interviewing medical students. And I just remind everyone, you don't have to have a degree in one of the basic sciences to go to medical school. I think it's actually really enlightening when people have come from other pathways, from the arts pathways and English, and they bring another whole dynamic to the class. So the science background is great and obviously very needed to become a physician, but you can still keep your options open and do kind of what you're most interested in. What I really loved the most in my undergraduate experience was actually I worked at Anne Arundel Medical Center in Annapolis as a medical scribe. So I know there's tons of scribe programs now, but this was really, really novel 20 years ago. And I got to work right in the ER, right next to the physicians, day shifts, night shifts, see every trauma and every, just run-of-the-mill complaints as well that came in there. And it immensely solidified my interest in medicine. And I think having that experience really gave me a heads up in my kind of my first and second year of medical school when talking to patients and talking about how you take histories and physicals. I already had an idea. And when we did, when people would be giving lectures and using terminology that often wasn't explained, I had already heard a lot of that medical jargon. So the medical scribe experience was tremendous for me, and I love it. And if you ever have an opportunity, I highly recommend that type of experience. And then I also did a bunch of, volunteer activities. Honestly, it's like almost 20, 25 years ago. I don't remember all of them. I remember I did Best Buddies and loved that. And also worked at the help center, like the counseling, the nighttime like counseling call center. And that was a great experience as well. So yes, so I did undergraduate. I went directly to medical school. I know a lot of people are taking gap years. Either way is fine. But I did direct to medical school, which I did also at the University of Maryland. So I'm University of Maryland, homegrown, started here, love it here, plan to stay here. And to some, that seems really boring. But to me, I think it just shows how much I like it. I'm also just very committed to my family. My family is here. They're a great support while going through medical school and residency, and my life in general really does take a village. So that's how I've ended up very homegrown in the Maryland system. So medical school, 4 years. The first 2 years are mostly academic. I liked the University of Maryland. They had a different system where we only did classes for the first 4 hours of the day, and then you really had all afternoon to solidify that with studying. They continue that, but they're changing their curriculum. So now it's not just, it's a little shorter than 2 years for that period. And that's really to gain more experience and electives and the ability to do research in those kind of 2.5, third, fourth year. So medical school curriculums are definitely evolving. So oncology is a subset of internal medicine. So I did 3 years of an internal medicine residency. I pretty much always leaned towards oncology. I dabbled in the idea of doing geriatrics for a little while, dabbled in the idea of palliative care. I did a summer program through the AAMC where I got to spend the summer in Chicago doing a hospice summer elective, I guess you would call it. It was a neat program because you were with about 20 other students from all over the country and kind of formalized under that AAMC umbrella. But ultimately, I went back to the idea of oncology. I did that in medical school. I don't know if I just made it sound like residency. That was in medical school. So residency, 3 years. And then I took a year. I wasn't quite ready to apply for my oncology fellowship. So I took a year as a hospitalist, meaning that I was the inpatient doctor. And then I did the 3 years of hematology and oncology fellowship. And now I've been in practice for, I think, another 6 years. So that is kind of how I got to this point. But I also got to this point during all of this. So I have 3 amazing kids. They are my pride and joy, and they really, really bring balance to everything that I do. And it's really important for me to, you know, for some of the things you see in oncology, to also come back and see just the innocence and happiness of kids. As a female and as a mom, and what often comes up, and we can kind of talk more about it, a lot of people ask me, when's the right time to have kids through all your training? There's no perfect time. And this is biology teaching you a lesson, because you really can't fully plan it. So I knew I was going to have a year off as a hospitalist. That would have been an ideal time. But Mother Nature didn't really think that was how it was going to be. So my oldest I had in my first year of fellowship. And I was so scared going into fellowship, knowing I was going to have to tell my co-fellows that they were going to have to cover for me and be out on maternity leave. And it all worked out. They were wonderful. I was one girl with 4 male co-fellows, but they were very, very supportive. Unfortunately, just the way fellowship works, and especially fellowship in having a baby in my first year of fellowship, I really had no days off prior to maternity leave, and went about 4 months after maternity leave before I had my first real day off. There are the regular scheduled weekend days off, which is really only 4 a month, but actually having, quote, a vacation day. For my second child, for my middle, he took quite a while to get pregnant with my first. Second one came right away. So that was really fun, telling my co-fellows less than a year later that they were going to have to cover for me yet again. But having him during my third year of fellowship, I had a little bit more time in electives, and it also gave me some time to reflect, now having 2 kids, on what kind of practice I wanted to do in oncology. And kind of, I'll talk about in a minute, the difference kind of between private practice and academics. But after having him, I realized that I really couldn't do patient care 5 days a week. So that was an awakening after having my second. And the little man, I had him during, I don't know, maybe my third year of being out in practice. And that was great because I got to take the 3 months of maternity leave. And, that was a special time. So I got to be an oncologist. I also got to be a mom of 3 wonderful kids, and I value both all the time. So here in the chat, if you can put in, when I say oncologist, what do you think? I just kind of want to see what the word makes you think about. And I really can't, trying to figure out how to see the chat for a second.
Yes, we're seeing them in the chat. There's mentions of cancer care, cancer doctor, chemotherapy, treating cancer. From Kumar, cancer doctor. From Milan, someone who treats cancer. From Sushil, managing cancer patients. From Priyansha, cancer care and research. From Eleanor, tumors. Morgan, cancer care.
Then that's all great answers. So when I think about the word oncologist and what I get, what comes to mind is being with patients through the extremes of ups and downs. So here in this patient, you see she's completed her chemotherapy, and we had the daughter brought in balloons and cakes, and we have a little frame here. We take their pictures, and we kind of had a party in the office. It was amazing. But also being there and being a part of the experience when patients do not survive their cancer, but how vitally important it is that you can always be giving support and to the patient and to the family to make that time more bearable. As I said kind of a little earlier, I was always very interested in palliative care, and it all goes together very closely, and it's really just a true privilege to follow a patient during these times. And this was one of my most special patients. I'm not weird. I didn't just sit there and like click a photo. They actually had other people taking pictures, and it was just a little tiny one that they then sent to the mom, and they have it framed in their house and everything. So it was socially acceptable. Don't think that I just go around taking pictures. But it really just, I think about that situation all the time. So some people, what do you think my typical week entails? The activities of my typical week, if you can add that into the chat. So charting, a lot of charting, examinations, good physical examinations. I am research, really important. I'm going to talk about that, about academics. Meetings, lots and lots of meetings, medical student teaching, one of my favorite things. Seeing patients, lots of writing notes, lots of consulting, lots of emails. Now you guys are all going faster. Checking leukocyte counts, yes, lots of lab follow-ups. Seeing referrals, giving tests. Doing both inpatient and outpatient. So all really, really good answers. So I tried to think about what my time breakdown is. I do patient care about 50% of the time, although that really definitely bleeds into other time, and you can't really separate out, oh, I only am going to do patient care on Tuesdays and Fridays. No, lots of things come out through the entire week. But I would say overall, about 50 to 60% of my time is patient care derived. About 20%, I'm the medical director for our outpatient cancer center. So I'll tell you a little bit more about that later, but it's about 20% of the time. 20% of the time, I'm involved in clinical trials or other projects. Other academic physicians, that might be way, way higher. And they don't have necessarily the medical director component, and their patient care might be less, and about 10% teaching. But just thinking in oncology in general, it's a big spectrum. You could become an oncologist and find a role where you don't do any patient care. If you go into big pharma or little pharma or regulatory, you could do maybe a half day of clinic a week, or even not, just give up clinical practice. Many people in private practice, they might be doing 90% patient care. But I really felt after having my kids that just mentally, emotionally, physically, I needed to be more balanced, that I love patient care. I love taking care of my patients. But doing that every day, I just thought was going to be too much for me, to kind of some of that emotional, I don't want to say baggage, but the emotional hurt and aspects that could go with it. So that's why really I gravitated to staying in academics. Definitely take a salary hit when you stay in academics, but I really love all those other aspects that I referred to. So for patient care, I'm in clinic 2 days a week, full day clinics there. I see inpatient consults throughout the week. The fellows and the residents, they just call and directly can request for any patient that's in the hospital if there's an oncology concern. And then I do about 6 weeks of inpatient cancer center attending. So I work with some NPs, they're wonderful nurse practitioners and physician assistants that take care of our cancer patients on the floor daily. But as attendings, we oversee and kind of direct them and the team and those care. So as medical director, and I never said before, if there's things that I'm saying that you want to put in the chat or zoom in on the, open up the conversation and ask a question, that's totally fine. So please do. Medical director and quality director, this is a rather thankless job, but with this, I'm really involved in a lot of the coordination between nursing, physicians, and how we do everything and how our practice. We're 23 physicians in our practice. So we need consistency. We need to have work patterns and workflows. So this is kind of where medical director role comes in. I get to see all the quality about if we're meeting benchmarks, if we're patient satisfaction surveys, and then come up with quality projects to include those. I also sit on our mortality review and any patient that dies in the hospital, or if there's a concern about their care. I'm also part of the decisions to review those cases. So that's a really important thing that we're always doing in medicine is going back and reviewing cases and seeing if anything could be done better. So fun new projects recently that I've been really a part of is we're actually getting a whole new cancer center building. It's going to be a 9-floor building on the outside of the University of Maryland Hospital. So it's been really fun to be part of designing that, trying to help with what would be layouts that, you know, the architect might not think about in how a daily the physicians and the nurses need something to be arranged. We had lots of new projects related to COVID this year and standing up testing and giving vaccine in clinic and just safety projects related to COVID. So that's been a lot. And our electronic medical system, we did a big, huge change over to electronic chemo ordering. That's been a lot of work to make that happen. So those are kind of the big things as medical director that I've done. Seen a couple of things in the chat. We'll come back to these things in the chat later, dealing with these issues, because I think there's going to be a lot of time at the end to talk about cases and emotional things. So I also said about 20% of my time is on clinical trials and projects. So I am not the kind of academic medical oncologist that has a lab. I have no desire to ever have a lab, no desire to do bench work. I enjoy doing translational projects with our basic scientists. Like I get them the tissues and the blood samples that they need, and I consult with them over whether their project, while it might make sense in the lab, if that's a clinically important thing when we're dealing with patients. So that's really fun. I'm the principal investigator on 5 of the clinical trials at Maryland. I don't have desire to be a principal investigator and design a huge multi-center trial. These are trials where they have been designed by other academics and we're bringing them to the University of Maryland, or our big oncology working groups have designed them, and I'm the investigator at our location. But other academic oncologists will actually design the big trials. I have one investigator-initiated smaller study, which is fun, but not kind of a big chemo study. So I do have a grant from Komen and ASCO looking at health disparities and developing a quality improvement project. So that's been a really neat experience. And then really into cancer survivorship and developing engagement activities. And then I do a lot of retrospective reviews. Somebody said, what are the requirements to be involved with research and become a principal investigator? That's a great question. So the requirements, oh gosh, it feels like so long ago that I went through all of that. You have to have a lot of knowledge and do some courses on research in human subjects and HIPAA and ultimately submit to the NIH a form that has what your training was and that you've done all those requirements and what your goals are. I feel that all of the training leads you up to it. So anyone who graduates as a HEMONC fellow would easily be able to fill out the forms to have the qualifications that would allow them to ultimately be a PI. You are signing your life away that you agree to all of the stipulations and regulations and that you're overseeing everything. And they do say lots of fun things about the FDA, the NIH, the Medicare can come and audit your research, but you will be able to have all of that going through a HEMONC fellowship. So yeah, I'm going to come back. And how long is the process to publish clinical research papers? It could be very variable. People who are good with it can get published in a matter. Well, first question is how long does it take to do the research? The research itself can take months to years. And then writing up the research and sending it to various journals can also take months to years. So it can be a long process. The Komen grant was a national grant, and we're the site within Maryland for it. All right. And then I'm going to go on to the other fun part of my job that I really like, which is teaching. So I do lectures to college students, med students, graduate, resident fellows. I'm usually doing at least 2 to 3 lectures probably a month. We also, in teaching our first and second year med students, we have now a course called Practice of Medicine, where we bring patients and students together to practice interviewing. So you don't just come to medical school and then all of a sudden know how to talk to patients. It's actually a very learned skill, but it's really great that you start as early as possible. So we start with our first year students right in the very beginning, bringing them and trying to instill. And it's really important because it's not just learning how to do it, but it's why you're going to medical school, right? So your first and second year, when you're learning like the Krebs cycle and biochemistry, you can sometimes lose sight of patient care. So that's why coming together with the Practice of Medicine is a really fun course. I've loved teaching that. I do a lot of informal teaching of the residents and fellows whenever we have a case. You know, I'm trying to spend, 20 minutes going over whatever learning points I can derive from that case. And then mentoring is, of course, a lot of fun. So any questions, Menhild, if what I missed in the chat boxes, any questions about kind of how to get to where I've been, and trying to scroll through.
Yeah, of course. We prepared 2 questions from the chat that I think that were about your family and life balance, the emotional roller coaster. So one asks, how do you balance the emotional roller coaster and dealing with your family to ensure the baggage doesn't affect home life?
So it sometimes can be a little bit difficult. My husband can tell the moment that I switch in my brain from being present with my family to thinking about patients. But I also think it really also helps me be a good mom, helps me put things in perspective, helps me realize what the little things are and what the big things are. So things I do is once I get home, so first I have a good 40-minute drive. So I usually kind of try to say as soon as I get into the house, from that time until the kids go to bed, that I am devoting to my family and not check my email, not check my patient portal. Sometimes my mind does go there, but I really try to bring it back. And I think my husband's been a great support in that. He knows that when it does go there, it's a really obviously I'm very affected by it, and he usually gives me a little bit of time to process or to make a patient call. Just, sometimes I just really want to check on a patient, and if I not sadly, but if I do that, I can kind of move on versus just continue thinking about it. So it can be different at different times. Yeah.
Thank you. And our next question for this part is, does your job ever entail traveling to different hospitals, either within or outside of Maryland, or to consult with other doctors or other organizations?
So for me, I only practice at the University of Maryland downtown campus. I very much like that it's just located one place. Other physicians do have multiple hospitals that they cover for. It can get a little complicated because if you're at multiple places, you can't take care of all issues that are happening at multiple places at the same time. But they have workarounds. They have, you have your colleagues that cover, you do a lot pre-scheduling and making sure that all works. But for me, I'm just at the University of Maryland. I consult with lots of other physicians at other places, the small community, and we reach out to each other and ask each other what we think about cases. Or if I know that there's a great clinical trial across town at Hopkins, I'm happy to send my patients there. I'll travel for going to conferences occasionally to give a talk. And obviously during COVID, we haven't had to do any travel in quite some time. Okay. And then there was one last thing about COVID affecting cancer patients. Unfortunately, it definitely has. We definitely know that patients are getting diagnosed later. It's also been tremendously sad that patients who are going through cancer treatment during COVID, not having their family and friends really able to support them in the same way as pre-COVID treatments. I have had patients that have been inpatient for 4 weeks and have not had a visitor, and that was heartbreaking. We do have visitors back in the inpatient cancer ward. You get like 1 visitor, which at least is something. But even at home, even outpatients, they're scared to see their friends that would have normally supported them through this time. So it's been a rough ride for cancer patients. All right, I'm going to move on, but at the end, there's still going to be lots of time for open questions, so you can keep them. Cancer 101. So how many cancers are diagnosed a year in the United States? So everyone can kind of put in what they think the answers here is. All right. So it's actually 1.8 million cancers. So there is a lot of cancer. Oh, I can share results. Oh, pretty. Oh, I might have messed that up. Sorry. Oh, it's just a chart. So a lot, cancer really affects a tremendous number of people. As we all know, you didn't need me to tell you that as a cancer doctor. What do you think is the lifetime risk for a female developing cancer? All right. 1 in 5, so 20% was what the most common answer, but it's actually much more common. It's 1 in 3, and it's even more common in men. So very, very likely to be affected in yourself, family, friends. And lung cancer contributes to the most cancer deaths. So here we see the most common cancers in men and women. So for men, prostate, lung, and colon are the most common cancers, while women is breast, lung, and colon. And here we see the lifetime probability for developing cancers as 1 in 2 for all males versus 1 in 3 for all women. Luckily, cancer-related deaths have been decreasing, and lung cancer really drives the cancer-related deaths. And here we see that lung cancer has decreased significantly over the last few decades. We are seeing a rise in pancreatic cancer and a rise in liver cancers like hepatocellular carcinoma, which can be related to Hep C, which definitely has had increases over the last couple of decades. And in females, the most cancer deaths come from lung cancer, followed by breast cancer. So while breast cancer really has really good survival statistics, and most patients survive their breast cancer, just the vast number of patients who are diagnosed with breast cancer. So breast cancer has a 1 in 8 chance of lifetime development of breast cancer, is unfortunately the second leading cause of cancer death. Really, really important, and we talk a lot about this at the University of Maryland, is the racial disparities in cancer care. So between all sites of care, white patients and Black patients, there's an absolute difference of 6% in survival. But you'll see, in certain cancers, it can be much more, even more significant. Oral cavity cancers, uterine cancer, really large differences. And here you can also see just the difference in the cancer death rates between white and Black and Pacific or Native Americans. Um, so in addressing cancer disparities, we can look a lot at whether they're, the social, economic, and biologic differences that can be contributed, and that is a large, area of research at the University of Maryland. We see patients really presenting at Black patients often presenting at later stages due to decreased screenings. And we have a community engagement team that's working to really limit, to decrease these differences that we see. So cancer. So when a patient's diagnosed with cancer, I really only expect them to hear about 5 or 10% of what I say after that word. So I know that when a patient is initially diagnosed, we're going to do a lot of education, but we're going to repeat it many, many times because it's such a life-altering diagnosis. There's so much that people contribute around it. Some patients won't even say the cancer word. They refer to it as the C word. So it's a, I always think it's like my job to walk a patient through it step by step. What I love about cancer care is that cancer care is so multidisciplinary. I like that I get to work with the surgeon, the radiation doctor, the pathologist, the radiologist, but also the social worker, the case manager, our dietitian. I am talking to these other people every single day. So you gotta like to talk to lots of people to do what we do. So beyond just those people, there's also a whole bunch of subspecialists. Our clinical pharmacist. I am super, super lucky that I have a clinical pharmacist who works in clinic with me. She's quite vital. We have a nurse navigator. And also just talking about the cancer team, really important to also mention that the patient's family and friends are really also an important part of the team. So cancer treatment, so every cancer is very, very different. Every chemo is very, very different. I frequently see, patients and doctors that think that kind of all cancer is the same. Certain cancers have much better prognoses than other cancers. Certain cancers are treated just with surgery. Some cancers don't get any surgery. The way we kind of divide them very simply is we kind of talk about our liquid cancers, which are the leukemias, and their treatments are basically chemotherapy based. And then solid cancers are organ based, and they usually involve a combination of surgery, chemotherapy, radiation, or hormones. But I really stress that it's a real need for multidisciplinary care. So any Cancer 101 questions? I've lost my chat box, so trying to find that. But if anybody wants to comment in.
Yes, we saved them for the open Q&A because we had more sub questions, but thank you.
Okay. So then I'll just go on to do kind of a virtual tour for a breast cancer diagnosis, because that is what I focus the most on, is breast cancer. So how does breast cancer present? So about 55 to 60% of the time, it is just based off of a screening abnormality. And it's amazing, the breast cancer has screening, and mammograms have decreased breast cancer mortality about 26%. So I kind of jump up and down for everyone to remain vigilant about breast cancer screening. Of course, there's also a lot of controversy on screening about what age to start and how often to obtain. And that could be a whole lecture in and of itself. But screening is very important, and it contributes to about 60% of our cases. A breast-specific abnormality attributes to about a third of the cases. So that's a patient presenting because they feel a lump or their skin looks different, or there's a difference in the shade or swelling in the breast. And then less than 5% of the time does breast cancer present due to some distant complication and found to be metastatic. So I brought a case. A 55-year-old presents after noticing a skin dimple and then a lump. She's very healthy, on no medication. She has a family history of a mother and a sister with breast cancer. So what would be the next steps? So just for the interest of time, the next steps, well, to talk to the patient, get their full history, but ultimately you're going to want to get a mammogram and an ultrasound. We call it a diagnostic mammogram when a patient's coming with a complaint, that the radiologist will be on site to request additional views to get the best images. A screening mammogram is just done where they take the pictures, and then if there's something found, they call the patient back. But if a patient has a known issue, you're going to do it by a diagnostic. So here I just clipped a picture of a mass and what an ultrasound would look like. Here's one of our awesome radiologists reading the images. So the next thing's going to be done is a biopsy. It can be either done via ultrasound, or sometimes they're done by mammogram directed or MRI directed. If they can feel a mass, an ultrasound would be just fine. But here's one of the biopsy. If they were going to do it, what we call stereotactically, that's kind of like a mammogram picture derived. And then the sample will be sent down to pathology. So I took a picture of our pathologist teaching reading room and their awesome microscope that has like 7 different heads so everyone can look at it together. Really, a good pathology review is so vitally important. You know, we trust our breast-specific pathologist is amazing. She has changed outside diagnoses that have saved patients from chemo or have led us to giving chemo that was necessary when the original pathology might not have said that. But, you know, here's just a pathology slide, all the things that they're looking at. They're looking at the grade, and they're going to stain it for things, estrogen, progesterone, HER2. They're going to give us a lot of information, and just so important to trust your pathologist. So for our case, the patient ended up with a 2.5 centimeter mass with some abnormal lymph nodes, and the cancer, it looked high grade. It was estrogen positive and HER2 positive. So these are receptors on the surface of the cancer cell that kind of drive both a prognostic and a predictive effect. So if it's HER2 positive, it's going to be a more aggressive cancer, but it also allows us to target the cancer with very special monoclonal antibody medications that have really improved survival for these patients. So in breast cancer, there are so many different treatment possibilities. So depending on the size, the aggressiveness, the type of surgery, all of these following algorithms, and there can even be more because they didn't even include preoperative radiation. But all of these algorithms could be possible. And that's why it's really important, again, to have this multidisciplinary approach so that you can all be on a team for the patient and present what ultimately you guys decide as the best approach. So for this particular case, if with it being HER2 positive and having lymph nodes, I'm going to want to do chemotherapy first. That would shrink the tumor. It would allow for better surgical outcomes. It will also give me prognostic information about the patient's long-term, how they're going to do, and additional treatments that if there's still cancer when they go to surgery, I might change things up a bit that might help their long-term survival. So for this case, we would, again, meet as a multidisciplinary approach, as a multidisciplinary team, and then ultimately decide to do chemo first, followed by surgery. And for what it's worth, for this case, the patient got a combination of 2 chemo drugs. So we typically do we do multiple different chemotherapies at one time when we're giving curative intent chemotherapy. And they got 2 antibodies that are directed to that HER2, which has been very life-changing in the breast cancer world. Ultimately, the patients have their choice between getting a lumpectomy, or we call it a partial mastectomy, and a mastectomy. Not all patients have the choice. Some patients, if their cancer is really big or it's in multiple portions of the breast, they'll be recommended for a mastectomy. However, if it's localized to only one area and it's of a size that cosmetically can be taken out, we would recommend breast conserving therapy, which is the lumpectomy, the lymph node assessment, and radiation. Lumpectomies with radiation have equal survival as mastectomies. And we really encourage, there had been a push to over-treat, and many breast patients, they hear in the community, oh, you just get a mastectomy, take it all out so you never have to think about it again. I think that has led to a lot of over-treatment. So we do a lot of counseling that if not necessarily, mastectomies don't necessarily have better survival outcomes. And now we're seeing an increase again back to kind of the breast conserving therapies when able. Things that, this patient had a very significant family history. We would do genetic testing, and if they had like a BRCA mutation, that might significantly change the plan. Radiation, again, is very important in patients who have breast conserving therapy or have positive nodes, and hormone therapy. Any estrogen positive tumor, I'm going to recommend taking an anti-estrogen medicine to help prevent it from coming back. So here's just a little virtual tour when you come in at the University of Maryland. That is the front of our cancer center. So this patient was going to get chemo first. We make the chemo on site at our pharmacy. And here you can see a little chemotherapy bay with the patient and the nurse. Sorry, the lighting wasn't so good that day. Getting the multiple bags of chemotherapy hung up. And they have their chair, and there's a little TV here. And now they can have a visitor back, so that's a important addition. And yeah, so I already talked a little bit about the surgery types. And here you can see one of our operating rooms. Operating rooms scare me significantly, so I don't have much to say here. Actually, I think it's one of our cardiac operating rooms where I snapped the picture from. This is a picture during the operation when we talk about lymph nodes. It used to be that we would take, so it used to be that the surgery, they took as much breast tissue and muscle, and then we've limited down to now the breast conserving surgeries. Same with the lymph nodes. It used to be that every patient would get an axillary dissection where they tried to take as many lymph nodes, but that led to the arms swelling, which is a huge quality of life issue if your arm's swollen and you can't do all your hand activities. It can be painful. It can prevent, have a patient who can't play the piano anymore, and that was her favorite activity. So now, if able, we do what we call a sentinel lymph node biopsy, where they inject a dye in the breast. It can be at the site of the tumor, or it can be at the site of the nipple, and it traces back to a special draining lymph node, which we call the sentinel lymph node. And you can take out the lymph nodes that either stain blue, or we can use a nuclear medicine Geiger counter, and you take out those lymph nodes and hopefully save the patient from needing a full axillary dissection. And here, again, radiation is a really important part to prevent the cancer from coming back locally. So here you see one of our radiation rooms, and lots of different types of radiation are available. So unfortunately, treatment comes with a lot of toxicities. So there are the acute toxicities that we often associate with chemotherapy: nausea, vomiting, hair loss, mouth sores, nail changes. There's surgical complications that can come up. There are radiation skin changes that are very prominent. So all of those acute cases are acute side effects, are dealt with immediately, and we try to minimize what we can. I tell patients, I'm not doing my job if you're home and vomiting. While movies might make it look like you should just accept throwing up when you're going through chemotherapy, that's not true. I always have more nausea medicine to give. I can give IV fluids. I can't take away all the side effects of going through chemotherapy. There could still be a little bit nausea. I don't have anything great for fatigue, but being home, sick, vomiting, there's always more that we can do. Having a diarrhea, there's always more that we can do. So I really jump up and down about using our patient assistance line and keeping in touch through our patient portal with our nurses or our pharmacists. These are kind of vital things to get patients through the acute part of treatment. Intermediate side effects are things that kind of span from acute to more long lasting. So, if we develop neuropathy during chemotherapy, a lot of times it goes away, but sometimes it doesn't. Same with chemo brain. We actually do think that chemo brain is, more and more being acknowledged as a real thing. Depression and anxiety is really common through treatment. And I actually even anecdotally see it increase right after initial treatment while patient starts their kind of survivorship period. So really, those are things that I'm always asking about. Long-term side effects, there can be secondary health issues, increased risk of cardiac toxicities, given some of the chemotherapies we use. There's the risk of secondary cancers related to the chemotherapy and radiation. And financial toxicity is, it costs a lot of money to be a cancer patient. Between co-pays, coming for appointments, lost income due to work, lost opportunities for promotion due to being a cancer patient. There's a lot that's we can't even quantify, but our patients know that that is happening and they're dealing with it on the back end. So things that we're always thinking about. But I like to show this video here. Oh, thought I could make it bigger. So this is one of our favorite patients. So I just love seeing everything that the patient at the end of treatment and how exciting that is, and ringing the bell at the completion of radiation is just such a momentous accomplishment for patients. To spend just a second talking about a minute talking about clinical trials. As an academic medical oncologist, I'm very interested in clinical trials because this is really how we move forward in treatment and finding new treatments and hopefully cures. It's been very interesting with COVID. I feel like everybody now has a little bit of a glimpse at what goes into clinical trials, although that was obviously very, very quick. Most trials do not run that quickly. But again, when there's a new medication that's showing clinical possibilities, they get approved by the FDA as an investigational new drug. And then we start clinical trials. So in a phase 1 trial, we're just going to have a few patients, and we're going to look to see if it looks safe. So phase 1 trials are really looking at safety. We have a couple phase 1s at university. We have a lot of phase 2 trials where if it looked safe, now you're expanding it and looking at the signs of efficacy. About 60% of phase 1s can move to phase 2. About 30% of phase 2s can move to phase 3 trials. So when you get that signals of efficacy, then you're going to expand it into a lot more patients and see if that remains, and compare it to other treatments. And then if it does, then it goes up to the FDA for approvals. And survivorship is really important to think about. So we get patients through their initial treatments, the long-term effects of cancer, kind of what I had spoken to in that previous slide. We also want to look at maximizing general health. I think it's really an opportunity to get patients in with their primary care to make sure they don't, develop, diabetes, to screen for secondary cancers. It's, very important to keep following these patients. And we know that we're just going to have an increasing explosion of cancer patients but very good cancer survivors over the next couple of decades. So cancer really is a disease of aging, and people are living longer and longer. We're going to continue to see new cancers develop in older patients, and we're going to see more opportunities to maximize the health of cancer survivors. So when I say survivor, you think we can kind of skip that portion. Just one little thing I'd like to say on metastatic disease. So not every stage 4 metastatic cancer is the same. So some stage 4 cancers are still curable. So it's very important to not go to the mentality that it's all the same. You know, even in non-curable cases, many stage 4 breast cancer patients can live years and years and years. So often we'll see patients get admitted to the hospital for some other reasons, and then we'll hear that they don't want to do an intervention because the patient has stage 4 cancer and they're not going to live long anyway. And then I have to come back and say, no, I think my patient's still going to live another 5 years. You know, I think it's appropriate to maximize their cardiac function or do a heart cath or whatever it is. It is very important to identify goals of care very early when we know it's not curable. And the role of palliative care can play. In my ideal cancer center, we would have every patient seen by palliative care at their initial diagnosis, and especially an initial diagnosis of metastatic disease, just to introduce the ideas of pain and symptom management being so important, to have another member of the team, and then to identify goals of care. So as they change over time, it's more natural. I think, unfortunately, very often in cancer care, patients really aren't aware of how sick they are until the very, very end. And you've taken, if you haven't been realistic and informing your patient all along, you've taken away a lot of opportunities for them to plan for their family. And I think that's really important. And then hospice care, a patient qualifies for hospice if you could expect that the disease could end their life within 6 months. Ultimately, I think we go to hospice way, way too late. And patients we know can sometimes even benefit from their services. They can get more social support. They can get supports of their families. That there becomes a point where chemotherapy is unlikely to help them and will likely hurt a patient. And at that point, we really need to be involving hospice. So they're really hard conversations to have, but I feel also very, very strongly that for the patient and their family, they're really, really important. So, not to end on a negative note, as you could see through there, there's so many positives in oncology and really special opportunities we have. So now, open questions.
Thank you very much, Dr. Rosenblatt. I'm going to ask Mira to continue our open Q&A session.
Thank you so much, Dr. Rosenblatt, for such an amazing presentation. To begin our Q&A, I would like to start off by asking one of our attendees, Christina, to ask her question to Dr. Rosenblatt.
There we go. Can you guys hear me now?
Yep, we can hear you.
Thank you.
Okay, wonderful. Hi, Dr. Rosenblatt. Thank you so much for the presentation. It was really interesting. And my mom last year was diagnosed with breast cancer. And so hearing you go through or talk through a lot of the stages was definitely reminiscent of the past couple of months for us. And my question was in regards to the survivorship period. My mom just finished up radiation and is going to be starting hormone. Easier to empathize, and when you see someone going through chemotherapy, it's easier to be like, oh, okay, like I should make sure that you're getting plenty of rest, lots of fluids, like, trying to give her as much comfort as possible. But I am not as sure what to do going forward now.
No, that's a great question, and is really, really important. And it's wonderful that you want to be there for your mom and realize it's an important time. And I think just naturally, everyone thinks that the patient is healing at this point. Their hair is growing back and they look stronger. But there's still a lot going on. I think emotionally, it's a really hard time because a lot of treatment, it's just go, go, go. Like chemotherapy, just get through it, get to the next cycle, finish your 6 weeks of radiation. Oh, you're going to heal afterwards. And then it's like, it's all done. It's like, bye, we'll see you in 3 months. But realizing that's a really high risk period for anxiety and depression. Also, when you start the hormone medicines, it's just a pill a day. That's easy. They still have a lot of side effects, less than the scary things we think about chemotherapy, but they cause hot flashes, they can cause aches, they can cause things that people don't want to talk about, like vaginal dryness and decreased sexual function. And I think a lot of doctors don't really address that at all. And it's an important part of life. So, just checking in a lot. So the survivorship engagement project that I was on, it involved a whole bunch of education sessions. They were virtual sessions addressing nutrition, pain, like maybe neuropathy is going on, maybe lymphedema is going on. So they were addressing nutrition, pain, mental health, sexual health, and it kind of had chat boards to discuss. And if a patient screened high on an anxiety, depression, it came back to me. And it was really nice to see that kind of support. So, for what that's worth. Good luck to your mom.
Thank you. That was worth a lot. That is very helpful. Sorry, a quick follow-up question. Do you know if the survivorship like meetings that you were talking about, are those available for patients and their families?
Right now, so that was part of a clinical trial, so it wasn't just like open to everybody. There are a lot of survivorship groups. So this is another really interesting thing on survivorship. Some people love survivorship groups. It gives them a community, a safe place to talk. Some people hate survivorship groups. They think it's bringing on every other person's problems onto them. They take it home. Somebody in the survivorship group relapses. They think that's going to be them. I think it's really difficult with social media now because your base population is not the 50 people that are in your life, but it's the 500 people or thousands of people that you see on Facebook, and seeing everybody else's stories. While sometimes they're uplifting, I feel like very infrequently do we see everyone who's surviving. I think that can be really hard on patients. So I don't know where that was going, but something on survivorship groups that each patient has to figure out themselves.
Thank you.
Thank you so much, Christina, and thank you so much, Dr. Rosenblatt. The next question asks, what is the prognosis of breast cancer in the elderly population?
So it can be very different. So some breast cancers in the elderly can very easily be surgically excised, and I can put them on hormone medicines, and they'll do wonderful. They're really young women have an increase, especially young Black women have an increase of the really, really aggressive cancers. So we see like a skew there. So some of the older patients, we see the more indolent estrogen positive cancers that do well. But every once in a while, an elderly patient may have one of those really aggressive forms, and the prognosis is worse. We have ways of doing geriatric assessments to help make the decision about treatments. You know, I say it's very, very easy to follow the algorithms and just do treatment and treat a cancer, but you really have to think about treating a person and put that in perspective. So the same cancer in a 60-year-old versus an 80-year-old, you might treat very, very differently. And that's a little bit of the art of treatment.
Thank you so much. The next question asks, on average, how long do chemotherapy trial projects take to be approved, and does it vary whether it is a retrospective or prospective study?
So approved meaning get through an IRB, that probably takes a couple of weeks or months. A retrospective study can usually be exempt. So you can put it in and just answer a bunch of questions, and then it comes back. They want clarifications, but usually we can do that in 2 weeks. A prospective trial that's involving treatments, it needs to go to multiple different boards. It has to be submitted and then go to our cancer review committee, which will do a first look. Almost always we have comments, and it has to come back to CRC for approval, and then go to the IRB. So that can be months. And if it's a large phase 3 trial, you know, that's just the development of it will take months and months.
Thank you. Is there any promising chemotherapy for breast cancer?
So there are lots and lots of promising treatments. That's what we're always looking for. So chemotherapy in and of itself is kind of a cytotoxic drugs that affect the cell cycles. The big thing right now in treatment is the antibody treatments and immunotherapies. So for triple negative breast cancer, we have had approvals on using immune therapies, so drugs that activate your T cells and teach the body to fight the cancer themselves. That's been really, really exciting. In HER2 positive cancers, we've had new drugs that are antibodies to land on that HER2 and bring the drug inside. And those are showing really, really further promising results. So there's, a lot going on. Targeted therapies to parts of the cell cycle for estrogen positive disease. That's also a really big area of exploration. So those are all exciting.
Thank you so much. The next question asks, what are the underlying factors that differentiate between a patient's good and poor patient prognosis? Or in other words, why do some patients survive and become cancer-free, and why do some don't?
So a lot of that goes back to that initial pathology, looking at how high grade and aggressive the cancers are. So they have mutations somewhere in that cell cycle in different places that lead to this low grade tumors still kind of have that shape, and they still look like a breast cell. But as they become less and less differentiated, they're going to be more aggressive.
Thank you. How do you manage patients who are under treatment for one cancer and later somehow suffer from some other cancer or multiple cancers? And why does cancer return after remission?
So a lot of times I do a lot of co-managing cancers, and we'll have a patient with just out of sheer bad luck, somebody has a breast cancer and then 5 years later has a lung cancer, or maybe an endometrial cancer that was related to the tamoxifen. Sometimes I'll just, depending on what the patient's preference is, at the academic institutions, I usually, for whatever that current treatment is, I would refer them to the lung cancer doctor or to the GYN doctor. In private practice, or I've had a couple of patients who just want to stay with me, they don't want to involve anyone else, I can also just manage it with, you know, further consultations when I have questions. So sometimes every once in a while, we'll have patients that are simultaneously diagnosed with 2 active treatments. And then we have to prioritize what treatment we're going to treat first, or decide if there's kind of a treatment that will quasi-treat kind of both of them. It's just a lot of multidisciplinary talking and weighing the pros and cons of different treatments and orderings for what that, hope that helps.
Thank you. What does the Cancer Survivorship Patient Toolkit include?
So that was the toolkit involved those sessions that I kind of referred to before on nutrition, exercise, sexual health.
Thank you. What causes chemo brain?
That's a great question. That's a big area of neurocognitive research. So I'm just kind of gonna think that there are changes that occur that we don't fully know the back mechanisms for.
Thank you. Have you come across cases of post-mastectomy lymphangiosarcoma?
So there are cases, so particularly angiosarcomas particularly develop in the situation of radiation. That's when we most commonly see secondary angiosarcoma. So it's a rare secondary cancer related with the radiation components.
How helpful are regular self-breast examinations as a screening tool for breast cancer?
So this will be surprising, but they have not actually been proven to be very helpful. They've actually been taken out of the national screening guidelines. So when I was in college, everybody had and they put on the shared showers, you know, these little hooks that had reminders to do your breast exams, and have a partner so that 2 people always did it on the same, you know, you would call your mom, everyone should do it on the 17th or the 14th of every month. They've actually taken that out of any screening guidelines at this point. They say just breast awareness. So it's not part of any screening programs at this time.
Thank you. How would you personally define quality of life when determining whether the negative side effects associated with chemotherapy outweigh the positives? And what are your thoughts on euthanasia and comfort life measures in the United States?
Oh, wow, those are very big questions. So the quality of life, so we have some quality of life standardized scales in oncology. We have something called the ECOG performance status or Karnofsky scale, but basically you have to be strong enough to get chemotherapy. So you have to be able to walk into my office, or if you're wheelchair bound anyway, but get to the office, be able to perform your activities of daily living. So if you're unfortunately kind of bedbound, not able to cook for yourself, not able to get dressed, do your cleanings, be up most of the day, you're going to do worse with chemotherapy. You know, it's a thing that I just can tell and know, and we can scale it on these scales. So that's kind of how we make those decisions. Euthanasia, is not something, so I mean, there's different areas of the country and different laws. I think withholding a treatment is something that, you know, we all know, and you could, but actively giving euthanasia is a very regulated thing. I am personally not comfortable with it. But I think that is a patient and a physician's choice in areas that have it. So that's my non-answer for you.
Thank you so much. What are your thoughts on cancer prevention, and do you think our food and lifestyles contribute to it?
So we know that cancer prevention is really important, that over a third of all cancers could be prevented. In breast cancer particularly, we know for postmenopausal women, activity and weight can be associated. We know that increased alcohol can be associated. That, you know, I think maximizing these things is good, not just for cancer prevention, but for everything. I mean, it's heart, lung, all of, like, everything benefits. So, you know, a lower carb, lower sugar diet is very helpful. Now, when you get into very specific diets of complete no sugar or complete organic, alkaline things, like, I think it's about things in moderation and kind of being more less processed. But I don't think that it's a I don't know where I'm going with that. I think we have to be cautious of how much we advise and how serious that becomes.
Thank you so much. What was your most difficult case in oncology, and how did you deal with it?
Most difficult case. I have a lot of trouble in general when I feel a patient is curable but has a very high risk of recurrence and doesn't want treatment or wants to go all naturopathic treatment, and concerned that I've educated them enough. And I kind of have this feeling, oh, if I just said more, if I just educated them more, I could change their mind. But often that's just not the case. And what I usually do on those cases is I talk to my colleagues, and they ground me back, and they say, look, you have had multiple deep conversations. You have told her all the facts. People can make their own choices. And that's kind of move on from there.
Thank you. The next question asks, how do you recommend deciding between different types of practice, academic versus private practice versus community, etc.?
So that kind of goes back to what I was saying in the beginning. I wanted to have multiple things going on in my life. I wanted half my time to be patient care, half the time to be doing other fun things. That was my biggest decision. I also only wanted to do breast cancer when the number of new drugs and new treatments that are available is exploding in oncology care. I think there were 14 new indications last year for treatments, and that's like year after year and increasing. So to me, I didn't feel like I would ever be satisfied that I knew enough treating all kinds of cancers. So I wanted to only treat really one main cancer. So that was another big part of choosing to stay at university.
What is the most memorable project that you've worked on?
Oh, the most memorable project that I've worked on. I've worked on so many fun projects. I think the most memorable things, though, are the things that you do with patients. So, I think that a lot of our outreach projects, I think I would probably say as the most fun and memorable things. So a lot of our health screening fairs and education sessions. So maybe not a clinical trial, but those are the things I think that hit me the most. The other things that hit me the most, actually, now that I'm thinking, is I've done a couple of home visits. I don't do them regularly. I think medicine would be tremendously different if we did. But I've had a couple patients on hospice that I have gone and visited them at their home. And it's given me such a different perspective of their whole life. You know, I can think of one patient who she had 7 kids, and she lived in kind of the inner city, and she had she's very young and had this advanced cancer, and I could never understand why she could never ever come to her appointments on time. And I remember one day, I don't yell at anyone, but I had a stern, like, you have to show up on time. It's really affecting all the other patients. I was giving her chemo like directly into her CSF through what we call an Omaya. So it was a procedure. So it wasn't just like a regular appointment. It was this whole 40-minute thing twice a week. And she would just come like whenever. And, you know, I kind of scolded her. And then when I finally went to her house when she was on hospice, you know, I just saw how was she supposed to take the bus and get here and take care of her, of all of her kids, technology for patients. And then of course our medications. I mean the technology and the advancements in medications since I've started, I probably have 8 FDA approved new drugs, not just indications, probably more. So that's of course a huge thing.
Cool, thank you.
Thanks so much, Justin, and thank you so much, Dr. Rosenblatt. For our last question, it asks, given your work in racial disparities, what are your thoughts on closing the gap between racial disparities to improve patient clinical outcomes?
So, I mean, I think that we have so far to go. And then until we invest heavily in financially in this and help decrease the gaps that aren't just medical, but the social and economic gaps, that there's limited to, I mean, there's always stuff to do medically, but I think that there's a whole social component and investing in the community that is really important. I also think that with our clinical trials, only 3% of clinical trial participants are Black. So that is also, you know, investing in that the trial mirrors the population is really, really important. So there's a ton of work to be done. Okay.
Thank you very much, Dr. Rosenblatt. We truly appreciate you taking the time to answer our questions. I love everyone to please give a warm thank you to Dr. Rosenblatt in the chat box for this incredibly informative session.
Thank you. It's been a pleasure. I wish you all luck. I wish you all were in clinic instead of just on Zoom. So hopefully in the next year, you'll all be able to get back and we can have more of a normality. So good luck.
Thank you.
All right.
Thank you so much.
Take care.
Take care. Now we're going to conduct our closing session with a few announcements.
We have had so many of our students ask us about how to keep track of their shadowing hours for professional schools, so we've added a resources page on our website for your reference to keep track of your clinical experience, community service activities, and extracurriculars. Just make a copy of the Google Sheet after clicking on the gray box at the top right of the Excel sheet for you to edit. In addition to this, we've also started a series of social media posts called How to Make the Most Out of Teleshadowing, which delve into things like note-taking tips or learning how to come up with good questions to ask during the Q&A. So follow us on our socials in order to see more of that. All of our social media handles are at TeleShadowing. The link to the quiz for this session is now live. We recommend that you finish this quiz as soon as possible as it's due in 48 hours and there are no extensions after the deadline. You'll need a 70% or higher to pass and receive certification. Now onto our next session dates. Our sessions are on either Fridays or Saturdays, given physicians have busy schedules and they're volunteering their time to mentor us. Our next specialty spotlights include pediatrics, radiology, and neurosurgery. These dates will also be posted throughout our social media outlets, so again, be sure to follow us. I'm looking forward to seeing you all at our next session next Saturday on April 10th at 10 a.m. Eastern Standard Time with our physician mentor specialized in pediatrics. Thank you so much, everyone, for attending